Hello, everyone. I'm Kevin Wilk with Champion Sports Medicine and the American Sports Medicine Institute in Birmingham, Alabama. And welcome to this issue of the American Sports Medicine MasterClass series. We're going to talk about shoulder labral injuries in the overhead throwing athlete. A couple of housekeeping points. Please mute the presentation, if you will, or your computer. And also for questions, please use the Q&A box at the bottom of your screen and not the chat room. What I'd like to do is introduce our moderator and medical director at American Sports Medicine Institute and also chairman of the board, Dr. James Andrews. He's also orthopedic surgeon and medical director at the Andrews Institute in Gulf Breeze, Florida, and also the medical director of the Tampa Bay Rays Major League Baseball team. Dr. Andrews?
Thank you, Kevin. Before we get started, I'd like to take a moment to thank St. Vincent's Hospital, which is our mother hospital where the Andrews Sports Medicine Orthopedic Center is, and also Kevin, which is part of Ascension Healthcare, for their support of ASMI and the MasterClass. They've been great partners, especially during this COVID-19 pandemic. I'd like to specifically recognize Andrew Nan, who is the president of the hospital and serves on the ASMI Board of Directors. With that done, I'd like to introduce tonight's faculty for you for this master's class and thank them for being able to share their experiences with you. We'll begin with Dr. Lyle Kane from the Andrews Sports Medicine Orthopedic Center here in Birmingham, whose topic will be fix the slap or biceps tenodesis. If you can figure that one out, Lyle, you're a genius. So what is the best choice in throwing athletes is what he's going to try to do. Lyle, of course, is an orthopedic surgeon at the Andrews Sports Medicine Center in Birmingham, faculty member of Sports Medicine Fellowship at ASMI, and he's also the team physician for the University of Alabama's great athletic program. Next up will be Kevin Wilk, who you just met. He's a renowned physical therapist and is Associate Clinical Director of Champion Sports Medicine, as well as the Director of Rehabilitation Research at the American Sports Medicine Institute in Birmingham. Kevin will share his thoughts on non-operative and post-operative treatment of slap tears. Kevin is also the rehab consultant for the Tampa Bay Rays. By the way, you can see I've got my Tampa Bay Rays shirt on tonight. We're still waiting for that World Series ring, aren't we, Kevin? Last but certainly not least is Dr. Glenn Fleissing. He's the Director of Research at ASMI, and he's going to talk to you about red flags and pitching mechanics related to labral injuries. As you know, Glenn is one of the foremost experts on baseball pitching mechanics, and he serves as chairman of the USA Baseball Medical and Safety Committee, as well as an injury research advisor for Major League Baseball and a pitching safety consultant for Little League Baseball. I would also like to congratulate Dr. Fleissing on an accomplishment that he has just been able to deliver, and he's been the driving force and also the first president of what they started as a newly formed American Baseball Biomechanical Society. That's the American Baseball Biomechanical Society that Glenn is the first president of and really got it all started. Congratulations on that great accomplishment, Glenn. And after Dr. Fleiss's presentation, we'll have some time for a panel discussion, as well as to answer questions from the audience that you can type into the chat window. I think, Kevin, you're going to run that chat window. Is that correct?
Yes, I'll run it.
So with that introduction, welcome to everybody. Appreciate all of you people that are out there, including therapists, trainers, doctors, and other sports enthusiasts and paramedical personnel who are here to help us get this started tonight. So with that, I'll go ahead and turn it over to Lyle Kane.
Thank you, Dr. Andrews. I appreciate the introduction. I'm going to talk about slap lesions and whether to fix the slap or do a bicep tenodesis. And I think, certainly in throwing athletes, that's where the major controversy comes in. In older athletes, it may not be as big a deal, but we'll talk about all the details. In disclosures, I am a consultant for Arthrex. We get research institute support from Biomed, Smith & Nephew, and Stryker, and others for ASMI. The goal is I'm going to talk about my current treatment of slap injuries, how I approach them, and then talk about the evolution of how it's changed over the past 20 years in practice, since I trained with Dr. Andrews 20 years ago. Now, SLAP by definition was coined by Steve Snyder in Arthroscopy of 1990. It's defined as an injury of the superior labrum that begins posteriorly and extends anteriorly, stopping before or at the mid-glenoid notch, and includes the anchor of the biceps tendon to the labrum. So it's outlined in this red area here. So normally it starts about, say, 10 o'clock on the clock face, extends across 12 o'clock, and stops around 2 o'clock, which is below the mid-notch or above the mid-notch of the glenoid notch. The problem is you can have a lot of variations we'll talk about in terms of SLAP lesions. Dr. Andrews was actually the first to describe it in 1985 when he started scoping shoulders and talked about glenoid labral tears that relate to the long head of the biceps, although the term SLAP lesion was coined by Steve Snyder. In general, we have a pretty, even 35, 40 years later, we have a very limited knowledge about the understanding the function of the superior labrum. We know that it's an attachment site for the capsule, for ligaments, for the biceps tendon. There are proprioceptive fibers in the superior labrum, so it probably helps with shoulder proprioception. The labrum in general, which the bicep attached to, deepens the glenoid, helps spread loads across the joint evenly, and enhances the joint compression and concavity, which gives you joint stability. Back in 1994, Freddie Fu and Mark Radosky and Chris Horner published a biomechanical study about the role of the long head of the biceps. And they said that in the abducted external rotated position, which is a throwing position, the biceps tendon and superior labrum contribute to anterior stability by increasing the resistance to torsional force. And they take the stress off the anterior capsule and the inferior glenoid ligament. Some years later, Bob Burks, in an instructional course in 2012, talked about the biceps itself, not the labrum, but the biceps itself. And we know that it's a strong elbow supinator, forearm supinator, but it's actually a weak elbow flexor, which I think surprises most patients. Most patients think that if you have a bicep tendon injury, you can't flex the elbow. That's not true, but you do lose a lot of supination strength. In baseball, it's important to decelerate the rapidly moving arm. So it's probably important to slow the arm down as you do ball release and follow through in baseball. And it's also a weak humeral head depressor and may, in that function, act as a shoulder stabilizer. Now, biceps tendon has been shown in several studies to have pain receptors. It has these alpha adrenergic receptors that cause pain sensation, and it also has sympathetic innervation. So the biceps tendon itself can definitely cause pain. In terms of the etiology of SLAP tears, it's been somewhat controversial. Dr. Andrews, in his first paper in 1985, described repetitive overhead activities such as throwing baseball. Steve Snyder talked about fall and outstretched arm, which is obviously a more traumatic SLAP type lesion. Giles Walsh in tennis players in 1993 described internal impingement, which is a combination of pinching or fraying of the posterior rotator cuff, as well as fraying or pinching and peel back of the posterior labrum. And then lastly, Steve Burkhardt and Craig Morgan in 1998 described the peel back phenomenon, which basically describes the biceps tendon with a posterior force peeling off the superior glenoid. There are some normal variants that are important for us as surgeons and also in MRIs. There's something called a sublabral foramen, which is essentially in the front anterior superior part of the labrum, where the biceps anchor attaches, the superior glenoid ligament attaches to the biceps anchor, and then there's a hole that's a natural hole, not a tear, in the anterior labrum, below which the middle and inferior glenoid ligaments attach. This is a sublabral foramen on axial MRI. You can see the labrum here. The sublabral foramen is a gap, and oftentimes that is misdiagnosed as an anterior labral tear. It is not a bad structure or pathologic structure. And this is what they look like surgically. So the sublabral foramen looks like a hole in the labrum or detached labrum, but it is a structural normal function anatomy. And so if you fix this and close it down or repair the ligament to the glenoid, you will by nature lose some rotation, which can be bad in throwers. The Buford complex is even more important. It's a cord-like middle glenohumeral ligament. Here, there's usually a deficient anterior labrum, and then the inferior glenohumeral ligament attaches to the lower part of the glenoid. It oftentimes is also mistaken for an anterior labral tear. This is what it looks like arthroscopically. So this is the middle glenohumeral ligament. Here's the deficient anterior labrum. And for many people, when they look at it initially, if they're not used to doing a lot of shoulder arthroscopy, they think that they need to reattach this as the labrum. back down the glenoid, when in reality, this is the metaglenohumeral ligament. And by reattaching it, not only do you over-constrain the shoulder, but you definitely decrease external rotation. A type 1 SLAP is a basic classification system which describes a frayed superior labrum, but everything's still securely attached. Those are usually treated just by debridement or smoothing the surface. A type 2 SLAP is by far the most common that we see in baseball players. A type 2 SLAP essentially, as we discussed, is posterior and anterior to the biceps attachment. This is a type 2 SLAP on MRI where you see fluid leaking under the biceps attachment as it goes between its attachment site to the glenoid. A type 3 is a bucket handle fragment, but the biceps anchor is still firmly attached. And a type 4 is a SLAP that includes a split up into the bicep tendon, and certainly a much more larger trauma type injury. This is a type 4 SLAP on arthroscopic picture, frayed posterior labrum and then a split bicep tendon. So the question is, what would you do to these different players? This is a 19-year-old college pitcher who's had pain for 6 months. He's failed rehab. He has normal cuff function, normal motion, and had an acute injury 6 months ago that started this. And on the arthroscopy pictures, he has a type 2 SLAP lesion. So this is a bicep tendon detached from the superior labrum. This is basically the same pathology, but a different player. This is a 47-year-old former college pitcher, now has several years of pain and difficulty sleeping, can't throw, and has some rotator cuff tendonitis, and it's more chronic pain. It bothers him with more normal things like sleeping. And then this is the worst case scenario. This is a high school pitcher who signed a baseball scholarship, but dislocated his shoulder playing football as a quarterback, and ended up with a complete rotator cuff tear, a nearly complete labral tear, and a type 4 SLAP lesion. So this is a totally different animal in terms of how you treat these players. So the type of pathology is certainly important. So generally what we do in Alabama is we ask the bird dogs for their solution. And I think there are a lot of options. We'll kind of go down the line and ask them what they would do. The first bird dog said cupping, that cupping is a good option. Increases blood flow, may make the shoulder heal. The second guy believes in dry needling. So certainly probably affects the nerve endings and maybe the sensation factor. And the last guy just wants to send him to sports psychology or maybe get the dad involved. If it's a young player, maybe the dad can shake some sense into him and get him back where he can play. But in most of our clinics, that's not the best option. We think we should fix it, right? So it's a torn labrum. It's not in the position it was initially placed. And so we generally think we should fix those. And that's been the treatment over the last 20 years. The problem is that these SLAP tears are oftentimes overdiagnosed. And in many cases, they're normal adaptation to a throwing shoulder. And in most throwers, they're asymptomatic. So when you look at asymptomatic professional pitchers, the vast majority have some labral damage or labral abnormalities in MRI. And so fixing a normal adaptation or asymptomatic thrower certainly doesn't make sense. And in many cases over the years, we have fixed normal anatomic variants, like a sublabral foramen or Buford complex, and that just constrains the shoulder. And the problem is if you over-tension the labrum or the biceps anchor, you lose motion, particularly external rotation, and that loss of external rotation can be the kiss of death for a thrower because they lose velocity. When you look at outcomes of SLAP lesions, there's a couple of systematic reviews. This was a little bit older. This is 2010. And really there's no good level 1 evidence or even level 2 evidence about SLAP repair outcomes. They're mainly retrospective studies that I'll go through, but the percentage of good to excellent results varies dramatically from 40% up to 94%. And previous level of return to play is even worse. It's 20% to 94%. One of the best studies out there was actually done by Dr. Andrews' group down in Pensacola. It's published in Journal of Sports Medicine, Orthopedic Journal of Sports Medicine 2019. 73 players, a mean 7 years after type 2 SLAP repair, which is isolated. So not rotator cuff debridement, not any other stuff, just SLAP repair. Most of these were college players and high school players, although there were 10 pros involved. And the really important part of this study is that return to play was 80% for pitchers, but return to prior performance, meaning they got back the same ability that they had prior to surgery or prior to injury, was only 52%. And what they found was that pitchers typically were younger at the time of surgery, they had more symptoms after surgery, and they also had lower outcome scores, the Western Ontario score and the VR pain scales. Another study from Houston, Texas in 2014 looked at 68 players. They randomized these people to rehab or surgery. And it's a pretty interesting study. in that they had 21 players finish a structured rehab program, only 40% returned to play, and only 22% returned to prior performance. They had 27 that underwent surgery for the SLAP lesion, 48% returned to play, but only 8% to return to prior performance. So not great numbers. Those numbers, when you look at them from any other procedure we do, is considered a round failure. It is definitely a failed surgery. So we're doing these SLAP repairs, putting things back where they were originally connected, but we're not having good outcomes. In that same study out of Houston, only 1 out of 21 pitchers with more than 30% partial rotator cuff injury returned to prior performance with either rehab or surgery. And so what we found is that the rotator cuff itself, not the SLAP lesion, and the integrity of the rotator cuff may be the key to return to play. There's been some EMG look at this from a biomechanical standpoint, and EMG, this was another study out of Chicago that looked at EMG after either SLAP repair or biceps tenodesis. And essentially what they showed is that with SLAP repair, there was altered pitching mechanics, particularly thoracic rotation, which probably relates to the tightness in the shoulder and the humeral joint. Whereas biceps tenodesis seemed to be the same mechanically as a healthy control. This study that we did here, published Dr. Andrews and our group in Birmingham primarily, showed 133 players with less than 25% rotator cuff damage had an overall return to play of 62%, and 59% of pitchers returned to play, whereas only 43% actually said it felt the same or better than before surgery. So not great outcomes in all of our hands. So the conclusion of that study was that it may allow a return to play in some players, but should consider it only after failure of conservative therapy. So we still certainly believe in adequate conservative therapy. So the question really is, what causes the pain? If a SLAP repair doesn't fix it, what is the issue? And really, SLAP symptoms are difficult to pinpoint. The tests that look at SLAP symptoms also have a lot of crossover with rotator cuff disease and other problems in the shoulder. And we believe that rotator cuff is probably the real problem when you get down to the basics. The biomechanics are very poorly understood, and we really don't know the difference, say, in the shoulder biomechanics for bicep tenodesis versus labral repair. We know that the pitching biomechanics are different, but we haven't really been able to determine what happens long-term after, say, a bicep transfer procedure. So the question is, what else can you do to these guys? Can you debride the SLAP? That's what Dr. Andrews did in the 80s and had really good results, probably better than what we had with repair. Biceps tenotomy or tenodesis, we'll talk about. A lot of people have gone to the posterior capsule release, popularized by Craig Morgan. The reality is that by itself has not shown to have great outcomes in pitchers. Anterior plication was popularized by Frank Jobe with an open anterior shift and also anterior plication arthroscopically, and has not had great outcomes. And you really can't, these players, we try to baby them, and I think most of our time is spent with these players is really kind of psychology 101 or 102 or maybe 401. But ultimately, you're not going to get them to give up baseball. So we have to find something to give them pain relief. So the question has come up, is it reasonable to think about tenotomy or tenodesis in overweight athletes? So I think the issue is determining why the proximal bicep causes pain. Do they have primary pathology like a partial biceps tendon tear, type 2 SLAP lesion, or in some young females, especially biceps instability? So there's a bicep pop in and out of the bicipital groove, which can cause bicep tendon pain. Or are they having compensation? Is it because of rotator cuff weakness or disease? Is it overused? Is it an MDI patient that their biceps is a secondary stabilizer and therefore not the original cause of pain, but just the place that they feel the pain? Fixing the bicep doesn't fix the underlying condition. So if it's a primary pathology, I tend to sway towards tenotomy or tenodesis, whereas if it's compensation for some other problem, then we try to work on the rotator cuff stability and strength, shoulder stability, and all the other issues that can cause these problems rather than address the bicep tendon. If you look at our experience here in Birmingham, this is kind of a difficult slide to read, but I'll show you the gist of it is that myself, Jeff Dugas, and Ben Emblem over the past 15 years, our SLAP tears have been, we've done about the same number of SLAP repairs over the last 15 years consistently throughout the whole process. But our tenotomy and tenodesis has been almost exponential if you look at the numbers. And the reason is because I think we've seen a lot of biceps tendon pain that continues after any kind of other treatment that we do. And so we've started getting rid of the bicep tendon. Now, we looked back at this, published it in 2017. We had 13 patients that were elite level baseball players, 11 in college, 2 in high school. The 2 in high school already had college scholarships, and all had a bicep tenodesis on their dominant throwing shoulder. 92%, 12 out of 13 of those returned to play after bicep tenodesis at the same level. The other player that did not return did not do so because he had finished his college career and was not drafted in the pros and didn't sign a contract. So the problem is that even though they got back, only 2/3 felt that their performance and their shoulder was the same or better than before injury. So, we got them back to play, but we didn't get them back to their pre-injury state. And the most common limitation was that they had a decrease in velocity and some subjective weakness in the shoulder. So not a perfect procedure by any means, but the majority, 12 out of 13, got back to play as pitchers. So in conclusion, why would we fix a slap tear? It's because, certainly it causes pain. It can destabilize the shoulder. It may protect the rotator cuff if you keep the biceps in place. And it doesn't burn any bridges like tenotomy or tenodesis does. You can't go back and reattach a biceps to the labrum once you've moved it. Why not fix them? Well, we know that many slap repairs lose motion. They have altered biomechanics pitching. Only 40 to 70% return to the same level of play. And bicep pain can return and remain after a slap repair, which is really disheartening for a surgeon when you repair a slap and you think you've done a good job, and a year later they still have bicep tendon pain. So why do a bicep tenodesis? Well, it removes the biceps as a pain generator. Certainly for primary disease, I think it's really a great surgery for biceps damage or tears. And then for secondary problems, if you can correct their primary problem, the bicep tendon oftentimes is still painful and you may have to do something to get rid of that pain. So why not fix it or why not remove it? Well, Dr. Andrews told me years ago, and I still hear it every time I do a tenodesis, you can't just cut it. It was put there for a reason. I think the problem is we really haven't determined all of the reasons for the bicep tendon. And so it always makes me a little bit hesitant to do it in a young athlete. In terms of my current algorithm, young athletes that have deep activity-related shoulder pain pitching, I rehab them as long as possible. I try to put them off from surgery. I try to reassure them. I try to spend a lot of time, telling them that slap lesions and throwers are very common and can be a normal variant, and we need to try to get through this without surgery because the outcomes are not very good. If it does fail, we do a slap repair. If they have primarily anterior bicipital groove pain, so not deep shoulder pain, but biceps groove pain only, then I'll sometimes do a subpec tenodesis, which is to tenodesis it under the pectoralis major muscle, or do a tenotomy depending on their anatomy. For a failed slap repair, I think tenodesis or tenotomy is a great option. For older athletes, I don't repair slaps because you can certainly overtension the shoulder, and you can take a 35-year-old athlete and turn them into an arthritic bone-on-bone shoulder by over-constraining them by doing a labral repair at that age. So I'm very careful about that. And certainly for the non-athletes or elderly, I think doing biceps tenotomy or tenodesis is the procedure of choice. But with everything we do in the shoulder, patient selection is the key. You have to determine their needs, their specific shoulder pathology, and what's going to work for them. Thank you.
That was great, Lyle. Outstanding presentation.
Thank you.
What I'd like to do now is discuss some of the non-operative approach, if I can. And hopefully I will complement what Dr. Kane was mentioning regarding this particular problem that we see with slaps. These are my faculty disclosures, none of which should come into play. It's a pleasure to be on this particular program. We have close to 500 people participating in this particular webinar, I should say, masterclass series on throwing shoulder. So please.
Kevin, sorry. You're not sharing your screen yet, Kevin.
Oh, it didn't show up? Great.
No, it's not sharing.
All right, hang on one second, sorry.
Okay, that's good. We see you now.
Yeah, we got it. Thank you.
Yep. So please remember to use the Q&A at the bottom of the screen as far as questions that you like to ask this expert panel, for sure. As Dr. Kane mentioned, slap lesions are super common. We've seen them in throwers, but other individuals as well. And one of the analogies that people use today are sometimes there's good slaps and sometimes they're bad slaps. And the bad slaps go on to have surgery many times. Many times the individual has problems at extremes of motion, such as a late cocking phase of the throw, and end range pain. And that's important from a rehabilitation standpoint. We need to target those particular areas where they're sore. But also lifting can be a problem as well. As Dr. Kane mentioned, there's numerous types of slaps. Some classifications go up to 10, 12. We're going to focus in this rehab, the non-operative approach in particular, on type 2 slaps, as you see here at the very top. So this is what we're basically discussing. Biceps in the upper right-hand corner here, as you can see, and here's this posterior superior detachment of the labrum. So what do we do from a rehabilitation standpoint? Well, as was mentioned previously, a lot of times what complicates matters is involvement of the biceps and involvement of the rotator cuff. In this arthroscopic view, you see this undersurface rotator cuff fraying and thinning of the rotator cuff. Many times in that scenario, that's a pain generator, and we would advocate using some type of intervention in rehab, such as maybe blood flow restriction, laser therapy, anything we can do to cause some tissue regeneration. You can see in these pictures of these throwers that these individuals are way back in these extremes of motion, and Dr. Fleisig will discuss this a little further as far as the mechanics with slaps and without slaps and so forth, but you can see how far back they go into external rotation and really horizontal abduction. This is some of the work that Dr. Fleisig has done at ASMI in the biomechanics lab. To the upper left is the biceps as it attaches to the labrum, and this is all the way back in that late cocking phase where the labrum is pulling off. And Dr. Andrews and Dr. Fleisig have written extensively on that particular topic. How common is it? Dr. Kane mentioned it was very common in professional baseball. Dr. Andrews and I and Jamie Reed with the Tampa Bay Rays did a study in 2000 in spring training where we MRI'd 31 asymptomatic baseball players reporting the spring training, similar as what's going on today in baseball. And 90% of them had something abnormal on their labrum. Not always a detachment, but many times some type of signal. 87% of them had abnormality of the rotator cuff, and 39% actually even had some changes on their humeral head. Dr. Miniacci with the Toronto Blue Jays at the time, he also documented about 80% of individuals on MRI who were asymptomatic had abnormal labrums as well. So certainly baseball can do it, but like Dr. Kane mentioned, it can happen through other things, as you see with certain exercises, especially overhead, especially ballistic type movements, fall onto outstretched arms. So the rehab has to match the type of labral detachment that we see. Dr. Kane mentioned that high school individual that had a 260 degree, 270 degree labral tear. That's obviously not a non-operative candidate. Whereas somebody who has a small detachment or fraying, type 1 or type 2 slaps, is a perfect candidate for a non-operative approach. We advocate active rest. Dr. Andrews has done that for years, saying that we don't want the athlete to rest completely. We'd rather them engage them in some active rehab, stretching, muscle activation, and so forth. So we'll talk about these concepts in a moment. Some things to realize with throwers. When I started some 30 plus years ago, we'll just mention 30 and leave it at that, most of the exercises were pretty low level. They were lightweight, laying on table, laying on a plinth or standing. Now we try to incorporate hips and core and your legs into the equation, your posterior chain. So instead of laying on the table and doing external rotation, I'd much rather you do something like this, where you're in a plank position, you're engaging your hips, and we do our exercises trying to incorporate the entire body. So we may start you on the table, but we're certainly going to progress you to a higher level. Many times adding tubing, as you see here, TheraBand CLX with manual resistance, but also using medicine balls, as you see here. This is a 2-pound ball where it does an eccentric, concentric type of flip up in the air. Always maintaining that plank. Here I'm adding in a rhythmic stabilization at end range with CLX. We can do it in standing. Again, with resistance bands, the person does these lateral movements, and as they do these lateral movements, we're engaging hips, core, and shoulder into the equation. Here, seated on the ball, by having the person extend their leg up on their opposite side, they're engaging their hip on the stance leg, which is his right foot and right hip, but he's also bringing the core of his body into the equation. The dumbbell in his left hand is creating a postural disturbance that he has to maintain good scapular position and endurance. So these are sustained holds. He's got a resistance band on his throwing side, so he's resisting internal rotation as well, and I add in a rhythmic stabilization at end range. Really tough exercise, but brings everything into the equation. Here, this person is in a side plank on a stability ball. We're using a halo, which is that aluminum bracket below, so the stability ball doesn't roll, which brings about more challenges. We can do this with other overhead athletes, not just throwers, but volleyball players. This person's a volleyball player, jumps overhead, resistance bands on legs and hips, so it incorporates this into the equation. We're always focusing on scapula. We're always focusing on the lower extremity, particularly your hips, I should say, your core of your body. So here he's doing a single leg squat while he does a retraction slide. So he's doing a reverse wall slide for the back of his shoulder. So this rehab program that we're emphasizing, non-operative, is a period of no throwing, normalizing motion, improving your strength, dynamic stabilization, and addressing the biomechanical faults that Dr. Fleissig will talk about shortly. So let's walk through some time frames, to put some time frames, if you will, or package this program in phases. The acute phase, the person comes in, they have pain. So what do? We use laser therapy, we get you moving, we use ice, and we also do stretching, which we'll talk about. We try to improve, it should be reduced instead of reduce, sorry, improve and normalize strength. So we do activation exercises, predominantly focusing on external rotation, scapula, hips, and legs, and work on a proper rehab program. From there, as they improve and can activate, then we progress them to our Throwers 10 program, which we'll show you in a second. And from there, we start being more of a complete shoulder program and not just targeting the muscle groups and the areas that they're deficient in. Phase 3, and this could be maybe a month after the onset or 3 weeks, we go to our Advanced Throwers 10, which incorporates sustained holds, holding the opposite side while the involved side moves. We do plyometrics, weighted ball throws, still stretching, still doing soft tissue, and preparing them for throwing. And then lastly, our throwing phase. We're monitoring the throwing, we're making sure they have proper throwing mechanics and they're doing it in a proper manner as far as distance and the number of throws. The cuff and the biceps is the wild card, so to speak, as far as if that's involved, creates a little bit more havoc, if you will, into rehab program. People often ask, what's your best stretch for the back of the shoulder? Many like the sleeper stretch. I'm not a big advocate personally of the sleeper stretch. I like this stretch better. I'm stabilizing this individual's scapula with my right hand, and I'm bringing his arm across his body to do a cross body stretch. We like this for posterior cuff. We like this for the back of the shoulder. We may do a modified sleeper stretch, and what I mean by that, instead of laying directly on the side, do a quarter turn back so you're in the plane of the scapula as you do this particular sleeper stretch. And they can do a cross body stretch on their own at home, laying on their side. Often people have talked about GERD and being a causative factor for SLAP type lesions. Realize GERD is only one piece or one aspect of the puzzle. We did a study looking at this, looking at total motion, and we found basically that when you add ER and IR together and you get total rotational motion, if you're outside that 5-degree window, you have a higher rate of injury. So we did an 8-year study with one professional baseball team, and we basically found that GERD did not correlate to shoulder pathology and shoulder injuries. What did correlate was total range of motion. If your total range of motion was off, you were more likely to have a shoulder injury. And also, a lot of external rotation was actually protective to the shoulder. So we try to correct any motion differences. One other aspect that I want to mention is we work on flexion as well. Here I'm holding the scapula, I'm bringing his arm overhead. We'll combine that with soft tissue, muscle energy techniques as well. And we'll also do some range of motion going into external rotation. What about muscle? Well, in the beginning phase, we want to activate your cuff, get your humeral head to be stabilized inside or within the glenoid fossa itself. So we do a lot of this. These are rhythmic stabilizations. It's a static hold. They hold that one position, and I just ask you at various angles just to hold that spot, co-activate. So you're turning the cuff on, anterior and posterior, and you're capturing that humeral head. So you're basically compressing the humeral head into the glenoid. Golf ball and a golf tee is the analogy. From there, we'll work toward manual resistance. So here I've got muscle stim on the shoulder in the lower right-hand corner as well. These exercises can be done with tubing and manual resistance, which I like to do a lot. So here I'm adding in manual resistance into external rotation with an end range stabilization. We'll also bring the arm up into the 90-90 position as well. So we start you down at 0, then we bring you up to 90, and make sure you're able at end range. Remember what we said in the beginning is most of these problems they feel at end range, either end range ER or end range and deceleration. So we have to work those phases, and we have to work on dynamic stabilization at end range. And as I mentioned, we're always targeting imbalances. Usually the problem is external rotation, scapular retraction, scapular depression, and maybe serratus protraction. The rest, internal rotation, deltoid, they're usually pretty strong. We're also working on timing and synchronicity. And some work was done at the Curl and Job Clinic years ago, as well as in Europe, that pointed out that a lot of overhead athletes who have shoulder pain, it's really an issue of synchronicity of muscle firing around your scapula. And we see this in young people a lot. If your scapular rhythms are off, many times they exhibit very poor mechanics with throwing, posture, but also can exhibit glenohumeral joint pain. This is an exercise we do a lot of for posture, posterior chain, lying prone on a stability ball, and the person goes into trunk extension, scapular retraction, and horizontal abduction at the same time. So they'll do their 10 reps, and on the 10th rep, what they'll do is hold one side, and they move the opposite. This, folks, is a very demanding exercise, and we like to do this a lot. These are called sustained holds. We published a paper on that in Physician and Sports Medicine some 4 or 5 years ago. People have looked at EMG activity. When you do the holds, the endurance is really emphasized, but your EMG actually goes up. As they progress through this non-operative phases, as they get better, we work toward plyometrics. 2-hand drills first, progressing to 1-hand drills, and then a throwing program. And today we're not able to discuss much of our throwing program. We hope maybe in our second MasterClass series, we may ask others to come in, maybe Mike Reinhold and others, to discuss long toss programs and different long toss programs today. A big trend that we believe in is that you would throw for several weeks, but actually take a deload phase. So you would stop for a week, maybe do a little light toss or no toss at all and let your arm recover and then start back up again. We also advocate 120 feet for pitchers. That's your long toss. And then you would bring it in the 60 feet flat and then go off the mound. Some people advocate long distance throwing, but it's never been our philosophy here to go 300 feet or 250 feet. Dr. Fleisig had done a biomechanical study on that, and perhaps he can elucidate on that later. But also during that throwing phase, it's also very important to do your stretching and your strengthening. Last couple of points, and I'll wrap this up, is endurance. It's critical for the thrower to do endurance type exercises. So we'll ask them to do these ball drops for 20, 30 seconds at a time. We'll do a variety of exercises. Here he's holding a dumbbell on one side. He does a ball drop on the opposite, and we do these rhythmic stabilizations. Really tough exercise to do. Posterior chain, posterior shoulder, and so forth. So to wrap up the non-operative approach, correcting biomechanics, which is a perfect lead-in to Dr. Fleisig, is critical. It's also very important not to stop your exercises. This is a year-round program when you're considering baseball. We've published several papers on this, our non-operative as well as our post-operative program. Dr. Kane mentioned this particular study already by Dr. Lintner. from Houston with the Houston Astros and so forth. Again, illustrating that non-operative approach can be beneficial and can be equally as successful as a repair. Lastly, I'll just mention this. What causes the pain, as Dr. Kane mentioned? Is it the bicep? Is it the cuff? Is it the slap? Well, it could be all three, but many times we believe it's more cuff, capsular, and biceps. With that, I'm going to stop there. Let me make a couple of announcements, Glenn, before you get started. For those of you watching on YouTube and Facebook, please send your email to ASMI Course Coordinator Caroline May at carolinem@asmi.org with your name and credentials, and you'll receive your certificate for tonight's session. CME and CEU certificates will be emailed in approximately 2 weeks. For the physical therapists on the webinar, you'll receive a certificate which you'll present to your state board for your credits. Also, you'll be receiving a course evaluation by email, and we appreciate you filling that out and making suggestions for the future. So with that, I'd like to end there and hand it over to Dr. Fleisig.
Thanks, Kevin. Okay, let me pick the right thing here. And, whoops. Do this. Okay, you guys can see my screen now?
Yes.
Okay, great, thanks. All right, following Dr. Kane and Dr. Wilk, I'm going to talk about the red flags in pitching mechanics related to shoulder labral injuries, which will tie it in nicely about what we can do on the field. First, I want to say my disclosures. I'm an advisor for Major League Baseball and also for Dari Motion. And my other disclosures, today is the anniversary of when I first started at ASMI. I want to thank Dr. Andrews for taking a chance on me 33 years ago, and I think we've done pretty well. Today is also Bobby Bonilla Day, as all Mets fans know. And in the year 2000, he had $6 million remaining on his contract. And instead of just paying him $6 million, the Mets decided to pay him $1.19 million every year on July 1st from 2011 to 2035. So happy Bobby Bonilla Day, Bobby. Today is also the first day Major League Baseball is back. And so they all reported for training camp today. So let's hope for the best for Major League Baseball this year. What I'm going to be talking about is the red flags for pitching injuries, for labral injuries in particular. And before I talk about the mechanics, I want to say overuse is the biggest single problem for injuries, shoulder and elbow injuries in pitching. But today I'm going to focus on the mechanics. The other factor is intensity. Now, more and more, there are pitchers who throw at full effort every pitch, and we've shown that that is not the recipe for success for either performance or for staying healthy. But anyway, today we're going to focus on red flags and mechanics. And we've been doing this for a long time. We've done more than 3,000 pitchers in our biomechanics lab at ASMI, from youth to major leaguers. And we've published almost 100 papers on this. And from the database, if we look at the best pitchers we've had in the lab who were healthy and threw close to 90 miles per hour during testing, we could conclude and see what is proper mechanics. We've had a lot of Cy Young Award winners, 10 different Cy Young Award winners in our database, and a lot of the top pitchers, both pro pitchers, major and minor leaguers, who are very successful. Hopefully this video plays with sound. This is just a quick blip of what the testing looks like.
When you arrive at the biomechanics lab, we will first begin by discussing the day's activities and schedule. We will then measure your height and weight and the flexibility of both your throwing arm and your non-throwing arm. We will then attach dozens of reflective markers to your body. When you feel game ready, you will then throw 10 or more pitches for the data collection. For each pitch thrown, the markers on your body will be tracked with our high-speed, automated, three-dimensional motion capture system. Additionally, the movement, spin, and velocity of the baseball itself will be tracked with our PitchFX system.
So with that, we calculate the kinematics of pitching. And kinematics is the fancy word for the motions, the angles, the velocities of the markers and how you move. And we also calculate the kinetics, the forces and torques. And my purpose today is to give you some practical points about some red flags, specifically what kinematics, what motions lead to higher forces on the labrum. And so I'm going to break down the mechanics looking at different instances, but it's important to realize that pitching is a continuous motion. It's really a kinetic chain, and you can see the pitcher here raising his leg. No shoulder injuries are happening here, but here we see the stride, and you need proper mechanics to get going. And still, the loads are rather low on the labrum of the shoulder here. But the stride ends at the time of foot contact. And what we've seen mathematically and scientifically in many of our papers is the position you are at foot contact is related to the stress on your shoulder and your labrum. So shoulder external rotation at foot contact needs to be like this picture where it's almost all the way up. The pelvis needs to have opened while the upper trunk still remains closed. And these are key mechanics for having not overloading your shoulder. From there, the body goes forward, the arm cocks back. We have the maximum external rotation, as Kevin was talking about, and Lyle. And then we go to ball release here. And then here's what it looks like at maximum internal rotation and the follow through. So some of the key things we've seen that are related to labral forces and torques are actually start from the bottom. And what we've seen is a direct correlation between your foot position and your force on your shoulder. Not your stride length, your foot position. So what I'm talking about is here, that's a proper foot position. But if the foot landed over here, that would be too open. You see how, let me move my mouse here. You want your foot to land a little to the clothesline of the back ankle, and that's proper. But if you land over here, that's actually going to lead to more stress, especially on the front side of your shoulder. Another key mechanics in the kinetic chain that's related to labral forces and torques is knee extension. You can see here at foot contact, the knee is comfortably flexed, and then by the time the ball is released, the knee has caught the weight and has some extension, has less knee flexion. And pitchers who collapse on their knee instead of doing this will have more shoulder force and shoulder torque, which could cause the labral injuries. Another important thing is, obviously, is shoulder abduction. At foot contact, the shoulder should be abducted about 90 degrees, and at ball release, the shoulder should be abducted about 90 degrees. The easiest way to see this is, it's really a three-dimensional motion, but the easiest way is to essentially say, is the throwing elbow on the imaginary line between the two shoulders. It should be from foot contact to ball release. In fact, here's a graph that shows a typical pitcher up until the time of ball release. You can see the abduction was low, but once he gets it up to about 90, he maintains it at 90. And the pitchers who keep their labrum and the capsule healthy will keep the abduction at about 90 from foot contact to ball release. And how the injuries happen is a labral injury or really impingement in the shoulder from having too much abduction or from having too little abduction. Kevin made some mention about external rotation again, and external rotation is important for pitching, but excessive external rotation could lead to shoulder injuries. And here's a little video. Dr. Kane referred to this study in 1992, but here's a video we made more recently of a picture of a patient, and you can see as the arm goes into external rotation, you can see the impingement of the, here's the labrum, and here's the rotator cuff and the humeral head, and you can see that what Dr. Andrews coined as the posterior or the internal impingement in the posterior shoulder. So if you have too much external rotation, that could cause injury like that. But Kevin and others, we've shown that insufficient external rotation is also correlated to a higher chance of injury. So you have to have just the right amount of external rotation, not too much, not too little. Insufficient external rotation has also been shown to correlate to ball velocity. In other words, if you can't crank your arm back far enough, you can't really accelerate it fast enough to get enough arm speed and ball speed. So you need a good external rotation to get ball speed. One thing which might be for a different day is weighted balls. Weighted ball training does increase external rotation. Our studies have shown, and it does increase ball velocity, but it also increases the risk of shoulder injury. I think some of you are familiar with the paper we published 2 years ago. Mike Reinhold is the lead author, but our second paper in the series just came out this week, again in Sports Health. It's on there, published online right now before in print. Again, showing that that weighted balls increase external rotation, but also increase the risk of shoulder injury. So essentially what we're saying is you need external rotation as a pitcher, but too much is a risk and too little is a risk. So essentially, throwing is a natural thing. What we're trying to do is avoid too much throwing, like Elf is doing over here. But throwing is natural, like this and like this. And the problem is nowadays, kids are doing single sport specialization and playing baseball or pitching all year round. So it's not that throwing is unnatural, but pitching all the time is unnatural. And there has to be a balance in development. So I've shown you that kinematic flaws can increase the kinetics, which can increase the chance of labral injury, which can lead to shoulder surgery, labral surgery. But what about after surgery? If you return, does it lead to kinematic flaws? Well, another study we did, published in 2014, American Journal of Sports Medicine, is we looked at pitchers who were healthy pitchers, college and professional pitchers, who had a history of slap repair. And we compared them, we picked 4 healthy pitchers for every one in that group, and we did a control group to see what a pitcher with a history of slap repair looks like compared to a pitcher with no history of injury, of surgery. And we matched them by height, weight, what level they were in ball velocity, and we reviewed their charts to confirm their history of injury. And then we used data for 10 full effort fastballs thrown in the biomechanics lab, and we calculated their motions and their forces and torques. And we compared them with the t-test. And this paper, of course, was published. And what we found was that we did a pretty good job of matching them. We got the same number of pros and height and weight. The age was a little different, but pretty much a good group. And they threw the same velocity. They were throwing 80 miles per hour during their testing. The slap repair ranged from 1 to 4 years post-op. And they averaged about 2 years, 22 months since their labral repair, their slap surgery, the slap repair. What we found was the slap repair group had less horizontal abduction at foot contact than the other currently healthy players. You can see the typical is 21 degrees of horizontal abduction, and the slap repair group only got 10 degrees. The slap repair also got less external rotation than the control group, about 10 degrees less. And at ball release, they had less trunk flexibility or used less trunk flexibility and had about 4 degrees less of forward trunk tilt at the instant of ball release. There were no differences in the forces and torques on the shoulder or the elbow between the two groups. So in conclusion, improper mechanics will increase the stress on the shoulder, which can lead to labral injury. Biomechanical evaluations can help pitchers and their coaches make sure they have the optimal mechanics to hopefully minimize the risk of injury. But it's not just the mechanics. It's the mechanics, it's how often you pitch, it's how often you rest, and how often you're throwing with full effort. These will compound the risk of injury. Throwing is natural, as I'll say, but throwing 100 full effort pitches every few days is the unnatural part. And as we found that mechanics after return from injury, when a pitcher returns from injury, you might want to consider what were the red flags that led to the injury in the first place. If he comes back with the same mechanical flaws, then he'll probably end up hurt again. So if he had some flaws that led to the injury the first time, you want to make sure you're not doing that. And as we showed in that slap repair study there, that the surgery and the rehab itself may predispose people for new types of red flags, in particular, less shoulder range of motion during pitching after having slap repair. As Dr. Andrews said, the last thing I want to mention is we did start the American Baseball Biomechanics Society. Here is their website over here, baseballbiomechanics.org. And 2 weeks from today, we're going to have a biomechanics online conference. So if you want to hear some more biomechanics, come join us at that thing 2 weeks from now. And I'll turn it back over to you, Kevin.
Great. Excellent presentation, Glenn, and excellent presentations to all. If our panel will unmute their computers, we've got some questions coming in. Again, for the participants, use the Q&A box at the bottom of your screen. Please type in your questions, and we'll try to answer as many as we can. We'll probably go for about 10, 15 more minutes. The first question is for Dr. Andrews and Dr. Kane, if Dr. Andrews is available, is how do you decide when to do a rotator cuff repair in a thrower, and what do you do in that scenario? So I guess they're a little concerned about that, obviously.
I'll go ahead and take it, Kevin. You know, I think rotator cuff tears in throwers are not very common, full thickness tears. Most tears are partial thickness tears. And so it really comes down to how much damage there is. We've decided over the last several years that rotator cuff repair also causes loss of motion, and especially so if you have someone that has you know, a 25% tear or less than 50%, we typically do a debridement. We just smooth it out, try to leave the intact fibers, and most of the time players can return to rehab through that. If you have someone that's got a full thickness tear, the return rate from repair is very low. We published our data. We had 13 patients with full thickness rotator cuff repairs, and only 1 of 13 returned. So a full thickness rotator cuff tear in a throwing athlete, you know, may not be recoverable, and you have to kind of get the play ready for that.
Another question is maybe for all of us. It's directed toward me, but it says, Dr. Wilk, in a scenario of a slap tear case that I had when I was doing my clinical rotation a couple of years ago, he lost a lot of external rotation. My CI was a big fan of low load, long duration stretching into external rotation. Do you have any thoughts on that and the loss of external rotation? So what I'd like to do is maybe have Glenn, if you would answer that as far as, you know, the loss of external rotation and throwing mechanics. I know you elucidated a little bit about that, but what are your thoughts on that, and how critical is it? And is there a critical number again?
Yeah, great question. Again, we've tested for the slap repair pitchers who've returned successfully. And like Dr. Kane was saying, a lot of them don't return successfully. So even when we look at the pitchers who do succeed, they still don't have full range of motion during pitching. I'm not talking about on the table, during pitching, as far as external rotation, but also horizontal abduction and adduction. And these are very concerning to me. The ones who we tested were still able to perform, and I can't answer why. I don't know how they still got their velocity. I think that's why they're the ones who succeeded. But I'm going to leave it to you guys, the clinicians, but I think it's tough for a pitcher to be back on the field with his full range of motion that he had before. And again, Dr. Kane was talking about there's reasons sometimes not to do surgery. I'll turn it back over to you guys, but it's hard to have it in pitching.
Yeah, let me say one thing, and I want Dr. Kane to mention a few things as well, if you would, is for me, if I have a thrower, especially at a high level, and they don't have what I consider enough external rotation with an injury or without, even pre-participation physicals, I am concerned. And that concern I have is on the table, the way I measure external rotation at 90 degrees of abduction, I would want at least 115 degrees passively. If they have less than that, my experience has been they often have shoulder pain, particularly cuff. So I'm going to toss it to Dr. Kane and maybe answer the question that was asked by the participant. But also, when somebody has a tear of their labrum, should you really suspect a loss of motion at all, or should you see an increase in motion if they have a classic peel back or a type 2?
Yeah, I think that's a great point. I think patients that have labral tears lose motion maybe because of pain or protection, but the labrum itself should not make them lose motion. So, you know, unless they've got a flipped bucket handle fragment, which is very rare, labral tear should give you more motion technically. And I think for a lot of athletes, tear is an adaptation to allow them to get more motion. And we look at the MRI, we see a labral tear. It's not very big, but it's definitely there. the player has made it through many years, through high school, college, pros, wherever it is, and they've probably developed as an adaptation to give them more motion. And then we go tie the labrum down, they lose motion. They get back to their pre-labral detachment state, and some of those players don't make it back. And so for me, I'm very conservative about fixing superior labrums in throwers, and it has to be somebody that's really proven they're not going to recover from rehabilitation, and they've got to have some kind of deep shoulder pain that I think is recoverable from a slap repair. And it's not a huge cohort. And that's why you look at the numbers over the last 15 years, it's been pretty stable. We haven't ramped up, despite the fact that we see a lot more players maybe with injuries than we did 15 years ago. The number of slap repairs are still pretty constant.
The next question
Can y'all
is.
hear me?
Yeah, we can hear you, Dr.
Kevin?
Andrews. Go ahead.
Yes, absolutely.
Yeah, let me just say one thing. In summary for what y'all been talking about, when I see a professional or any baseball player at any level that comes to see me for a shoulder problem, the first thing I do is I look at them and I hope it's their.
Okay, we lost you again. You went on mute now. Your phone went to mute.
Hopefully we'll be able to get Dr. Andrews back engaged. He's having some connection problems, evidently, streaming. So the next question is total range of motion in the overhead athlete.
Yes, we can hear you now. You're back.
I was just going to tell them, the first thing I tell a thrower is the last thing you do is have your throwing shoulder operated on. That summarizes pretty much what we've said so far. Go ahead.
This total range of motion number, ER and IR together, what should we have? Well, for me, we've published several papers on this, but just realize it depends on how you measure, how much overpressure you put into it, and how you stabilize the scapula internal rotation. But what we strive for, the way I measure, is about 183, 184 degrees of motion. That's ER and IR together. The next question is, for unilateral dominant athletes like baseball players and volleyball players, which Dr. Fleissig, you published some papers on volleyball players as well, how critical is bilateral strength mobility? Is it important for overall management or during the rehabilitation post a slap repair? So I think what they're asking is how much of a difference one side to the other. So maybe, Dr. Andrews, are you available? I don't know if you're connected right now, but you've examined more than anybody on the planet as far as overhead athletes, as far as I know. How much of a difference do you see when you do your clinical exam? And then maybe Dr. Kane and Dr. Fleissig can comment.
Well, you expect the overall range of motion to be about the same total motion, but your external rotation on the throwing side is usually about 15 degrees greater than the non-throwing side, and your internal rotation on the throwing side is 15 degrees less than the internal rotation on the non-throwing side. What you're looking for is a total arc, though, like you talked about. So all of your motion is geared toward external rotation. That's why kids have to throw when they're young, because they torque their growth plates and get retroversion of the humeral head, which allows more external rotation for acceleration of throwing a baseball, but it also allows for less internal rotation in most cases.
What about the strength, Dr. Andrews, when you're doing your clinical exam?
Well, as you get further up the ladder in professional baseball, for example, they all lose some strength in the adducted position against external rotation. And they just almost all have it, and you usually can't get that back. But they seem to throw at a high level. And being able to do that depends on their genetics. It depends on how good a baseball player they bred into being, period. And the difference is everybody that wants to be a professional baseball player don't have the genetics to hold up to throw. So the ones that make it go through all these minor injuries that we see in young throwers. When they have it in young throwers, their genetics is not going to allow them to really be big-time baseball players. They're in the wrong sport. You can't tell them that, though. They won't listen to you, but they're not going to be baseball players.
Dr. Kane, so when we do our clinical exam and they're a little bit weaker in the external rotation, should the clinician be concerned about that or just accept that?
Well, as Dr. Andrews said, I think it's very common the further up the skill set you get, and some of that probably adaptive. Some of it we've shown in studies that people looked at, it happens over the season even, and in games. So if you check a player's strength at the beginning of a game, end of a game, they get weaker as the game goes on. Beginning of the season, end of the season, they get weaker as the game goes on, or the season goes on. So, I think it's somewhat just part of using those muscles repetitively in throwers. I think if they have a big deficit, you do think about some pathology, such as suprascapular nerve impingement or compression by assist. There are things that can cause labral-related abnormalities that can cause some infraspinatus weakness and cause weakness in external rotation. So it shouldn't be dramatic, but oftentimes there is a subtle difference in strength of the dominant arm versus non-dominant arm.
Dr. Kane, that's a great point regarding the infraspinatus and suprascapular nerve. Dr. Andrews, certainly during pre-participation physicals, you've seen countless numbers of overhead athletes that have the atrophy of the infraspinatus or maybe the supraspinatus, and you suspect a suprascapular nerve involvement. What should be done in that scenario? Should studies be done, or just careful observation of that individual, or what?
Well, the puzzling thing is you see that frequently in high-level elite major league pitchers that are throwing 90-plus miles per hour. And you look at the back of their shoulder on physical exam, and the infraspinatus fossa is completely void of infraspinatus muscle. Now, the supraspinatus is different. But when it's isolated to the infraspinatus, you ask them about it, say, well, I never have seen that before. I couldn't see that in a mirror. They don't know when it happened. And most of the time you're worried about, is it chronic? And most of the time it is chronic. Yet they can throw at a high level with that muscle atrophy. So if you see it fresh, you might do studies, figure out if you've got a compression of that branch of the suprascapular nerve to the infraspinatus. But most of the time, even if you decompress that, it doesn't come back. And the thing is, you don't know when to do that, when not to do it. Most of the time, it's chronic and it's not causing any symptoms at all, which is an enigma if you want to know the truth.
Right. So just keep an eye on it, perhaps. Skillful neglect.
Rehab them.
Yep.
Yeah.
And I would recommend maybe putting muscle stim on those individuals, put it right on the electrodes right on the infraspinatus, if that's where the atrophy is, and do your resistance. Dr. Fleissig, you published a couple of papers on that called the infraspinatus syndrome in volleyball players. Would you mind mentioning a few things on that?
Sure. I just want to, because that is an overhead athlete, as we say. I just want to say one thing, follow up to what all the doctors have been saying here, which is some of the players lack external rotation, and then you have to work with the physical therapist or whoever to regain that. I don't think we want to take it too far where the healthy pitcher has normal external rotation. I don't think you want to train or try to stretch out to get extra external rotation, to get extra ball velocity. That's a dangerous area to go. So I think all your work on getting more external rotation is for the pitcher who has a deficit of external rotation. As far as volleyball goes, the volleyball during the spike and the hard serve, they go through a motion similar to throwing, but the difference we find is that the abduction is not 90 degrees. It's more like 105 or 110 degrees. So it leads to more superior impingement syndrome type situations because it's still going through external rotation. They have repetition and a rapid internal rotation, but it's with more abduction. So that's why it's a slightly different pathology and risk for the volleyball players.
Here's a question for the panel, and I know it hits home with Dr. Andrews quite a bit. Do you believe in year-round throwing, utilizing off-season, specifically designed throwing programs in preparation for the upcoming season? Or does the research support taking a few months off and shut down entirely?
Well, we know that the risk factors for injuries in youth baseball pitchers is fatigue and velocity. And fatigue comes in three types. One is event fatigue, too many pitches in a game. Seasonal fatigue means too many innings in the season. And year-round fatigue means playing baseball year-round. So we recommend at least 2 months off each year for the arm to recuperate through active rest without any overhead throwing, preferably 3 to 4 months. the reason I try to tell parents to think about that, everything in Mother Nature has a rest period. We rest our fields where we grow crops. We rotate them to let the field rest when we grow crops. We have Sunday, according to what the Bible taught us. We have Sunday off for rest. So everybody needs a period of rest for recuperation, and so do young baseball players.
Dr. Kane?
Yeah, I agree. I think, we definitely see it in the last 20 years, there's been a trend towards more year-round throwing. I had a kid in the office yesterday that I was asking about it, and he said, I took the fall off. I said, did you not play baseball? He said, well, I did instruction. I had a pitching coach. I did some training. I did some camps. I did some showcases, but I didn't play for a team in the fall. And, realistically, he was throwing the entire year, although he thought he was being real protected. And so, I think ultimately not throwing a baseball, but still keeping your body in shape, exercising, working out, keeping your arm in shape is important. Doesn't mean you have to just, be a couch potato, but I think it is important to give the arm rest because it can't handle 12 months at a time.
Dr. Fleisig?
Yeah, we've done a lot of studies in 33 years, but the studies with the strongest findings for sure, facts, are overuse leads to pitching injuries. And we've shown that an adolescent who pitches more than 100 innings in competition in a calendar year is far more likely to have injury. A pitcher who continues to pitch when he's fatigued, subjectively, gets injured. It is the strongest research we've done is on this overuse. So if there's anything to do, if you want to stay healthy, don't pitch all year.
Couple last quick.
Kevin?
Yes, sir.
Bring that point home. Our research that he's talking about showed that if you pitched with fatigue in youth baseball, any one of those fatigue factors, you had a 36-to-1 times in our research papers that were published peer-reviewed. 36-to-1 times. That's 3,600% increased chance of having a hurt shoulder or elbow in a thrower. So if that doesn't get everybody's attention related to fatigue, nothing will.
Let's do two more quick questions and we'll end this. Questions are rolling in. I apologize we can't get to all of them. One of them is for Dr. Kane, who several people are calling you the bicep killer, by the way. I don't know what that's all about, but somebody, you must know them. What is the time frame for return to throwing after a biceps tenodesis and or a biceps tenotomy?
Yeah, so I guess both procedures. The difference, really, for me, is that to heal the glenoid, we're very slow in the early rehab process. So we limit range of motion, we limit rotator cuff exercises, and it's a much slower rehab. With biceps procedures, whether it's anatomy or tenodesis, you can allow the patient full range of motion earlier. Hopefully, you avoid loss of motion in general. And you can do rotator cuff strengthening earlier, even though you can't do biceps active. And so, I think it's a little bit faster. I'll generally let biceps tenodesis starting throwing program around 3.5 months instead of 4.5 months for a slap repair. But ultimately, we still worry about the bone healing, the biceps healing. And I think the overall time frame is still similar between a slap and a biceps. It's just that they don't lose their motion as much because you move them earlier. So it's, return to play. On our study, most of the players got back around 9 months to play. Not significantly different than a slap repair, but the process is a little bit faster on the front end.
Here's a question I'll handle, and I'll toss it to Dr. Fleisig for a moment as well. In the conservative approach, how important are the hips involved in shoulder rehab, but also in the mechanics of throwing? I can just tell you that's what I tried to focus a lot on, is not the isolated exercises, but bringing in hips, posterior chain, especially in these young people that are weak in their posterior chain, weak hips. I think one of the first tests you should do with a young thrower is a single leg squat and see how well they can stabilize their balance, their body awareness, but how their lateral hip is. Glenn, have you done any studies on hip and core with the biomechanics of throwing?
Well, some of the stuff is very hard to measure in the biomechanics lab. The pelvic tilt is very hard to measure with our motion analysis. What we do measure is the pelvis rotation and trunk rotation. So I do think the pelvic tilt is very important, but and the spine, curvature of the spine are really beyond the accuracy of our system. I do want to say that I've been talking about the shoulder a lot, but the timing between the pelvis rotation and upper trunk rotation is very key in the kinetic chain. It's not exactly what you were asking about there, but the pitchers who essentially rotate their upper trunk and lower trunk at the same time are not building energy in their trunk and just throwing with their arm. So the proper separation in pelvis and upper trunk is important, and also the legs passing the energy to the pelvis and hips is important.
Question for Dr. Kane and Dr. Andrews. Do you do single rope, I mean row, probably a typo, single row or double row? And do you differentiate between different types of athletes for your cuff repairs?
Double row.
Double
Yeah,
row?
Yeah, double row.
Triple
for
row.
Sure. Yeah.
Triple row.
But you know, it's important, Kevin, to remember that the study we did on our throwing athletes with complete cuff tears, again, 1 out of 13 made it back to the same level. So, you know, a complete cuff tear is a bad injury in a thrower. The partial tears, I think debriding them, they do better than repair in general. We do repair the rotator cuff if it's really deep, partial thickness, or if they've had a failed previous debridement. But those players have a pretty poor outcome in general.
Would you agree, though, that position players can do better with a cuff repair than a pitcher?
Absolutely.
Okay.
Yeah, no doubt.
Last question, maybe we can go around the horn, start with Dr. Andrews. It's from Zach, and he's saying, here's the $1 million question. What are your thoughts for the people who did not make it back to play after a slap repair? What do you think the reasons are?
They should have gone to another doctor. No, we don't know the answer to that. I think it has a lot to do with their natural talent to be a baseball thrower. And a lot of them are what we call wannabes, and they're in the wrong sport. And it makes it almost impossible for us to fix them. We see the same injury in a high-level elite thrower. Let's say their daddy was a major league pitcher. They've got the right genetics, and they have the same injury, and they don't have any pain. So it's an enigma a little bit trying to figure out who do you operate on. And in my experience now, I can almost look at the player, even though I may go ahead and operate on them. I'm doing it reluctantly. I don't tell them this, but I say to myself, I hate to be negative, but I say, if this guy makes it back to a high level and go up the ladder in baseball, it'll be a miracle. And it probably won't be my surgery that does it, but it'll be whether or not he's motivated and how hard he works. But it's an enigma to some degree.
Oh, sorry.
Dr. Kane?
Yeah, you know, I think, you know, Dr. Andrews mentioned there's a lot that goes into not making it. You know, some of it is the mechanics of the way they throw. Some of it may be their skill set in general. I think from our technical standpoint, most of the people don't make it, in my mind, or because they have significant rotator cuff disease or because they lose motion. And so, you know, as we mentioned multiple times, I think if you're going to repair a labrum in a thrower, you got to make sure they get their motion back to their baseline at least. And if they have significant rotator cuff disease, the cat may be out of the bag. You may not have a good option for them. And the less aggressive is usually better.
Glenn?
Kevin, one other point that you need to make to the therapist is that some of the reasons that the surgery fails is because the patient wants to jump right into I have one that I saw today that has had pain for 2 weeks, a high level senior in high school going to college to play shortstop. Has a pain for 2 weeks, saw a surgeon, didn't have any rehab, wanted to tell him he had a slap tear and needs to be operated on. Well, when you do that, your chances of getting them fixed are almost zero. You can't operate on any kind of shoulder problem unless you've had failure of conservative treatment. Usually conservative treatment meaning you did it under your supervision, like with you. And if they fail conservative treatment, all that you've done is prehab. And then your chances of getting them well, regardless of what surgical procedure you do, goes a little bit better than if you just do them cold without having all that conservative treatment and prehab, trying to figure out whether they really need an operation or not. So a lot of that is because they get operated on too quick.
Yeah, Dr. Andrews, to your point, I think, you know, so many times, whether you're a physician on the call now or therapist or athletic trainer, you have an athlete who comes in and they said they did rehab, you've got to sit down and talk to them and figure out what they did in rehab. Rehab is not all the same. And also in different hands, it means different things, even the exercises, technique. So when I hear somebody failed rehab, I still go for it. You didn't fail my rehab, and I hope the participants have that same attitude.
They were doing their bands.
Right. Whatever that means.
Yeah.
Why do you think? Oh, I'm sorry. Go ahead, Dr. Kane.
I was going to say one more thing. I think, to Dr. Andrews' point, it's when a player comes in and they've had a diagnosis or they think they have an injury, it's really easy to convince them to have surgery because most people are looking for a quick fix. It takes a lot of time and a lot of education, a lot of time with the family and the patient to convince them not to have surgery. And really, it's harder. It's much easier to say, yeah, we'll go fix it and let the chips fall where they may, but it's hard to convince them not to have surgery. And that's what we spend most of our time doing.
Especially when, so many people do have slaps that are throwers. I mean, you could be doing surgery on almost everybody who's a high-level thrower. Dr. Fleisig?
The saying is that if you want an excuse to operate on a throwing shoulder, to your point a while ago, if you want an excuse to operate on a throwing shoulder, get an MRI. That's the problem.
Okay, Kevin, just to reiterate what you clinicians are saying, surgery should be the last resort for one of these injuries. What they should focus on is conservative treatment with someone like Kevin, and rest. Perhaps they need some rest and maybe adjust their mechanics. So surgery should be the last choice.
So with this, I think we're going to conclude. Obviously, we can keep going with questions. We have a lot more to go. We had about 500 people on at one time for this particular webinar. So I think it was hugely successful. I hope we'll do it again. I hope ASMI, the American Sports Medicine Institute, will certainly support this, maybe talk about cuffs or UCL in the future. I want to thank Drs. Andrews, Kane, and Fleisig for taking time out of their incredibly busy day to do this particular webinar. And I also want to thank the participants for, on a Wednesday evening, taking the time out of their day as well. I think it was very, very beneficial. Don't forget, you'll receive an email that will give you your CU instructions and so forth. And we appreciate American Sports Medicine Institute's involvement in baseball. And go to asmi.org for more information and pitch counts and exercises and ways of making your throwing athletes better. So thank you very much, and stay safe, and we look forward to seeing you on our next webinar. Thanks so much.
Thanks, guys.